We've got two aims in public health. The first one is to improve the health of the population, and the second one is to make it fairer and to reduce the health inequalities. What is my role? And I think in many respects it's as a facilitator. It's trying to bring people together who may otherwise not have either met each other or who would never have thought of each other's work in a common context of health. What I need to be doing is getting people to change what their focus is. We do a lot of work checking kids, so there's a lot of our health and of our public health budget goes into prevention at an early age, and I think when you combine vaccination, health visiting, school nursing, all of those interventions, a lot of dental care, etc. We do quite a lot at an early age. We just sort of stop doing that somewhere around where people are 20 to 30. Now the next question, I guess, is when do the behaviours that lead to ill health arise, and could we do more around those for people in their 20s and 30s? The answer is probably yes, but that's just not the way we've set up the service at the moment. We have a service that's very much based on you will come to me when you're sick, and there's a question whether we could afford with the current budget to move to that kind of more preventative model. It would be lovely to, but at the moment I think we're so busy dealing with the problems that have arisen that there's very little money left to go into doing more on the prevention side. Based around the origins of the National Health Service is that it's not a National Health Service, it's a National Illness Service. It's a great service if you're sick. Southampton has, as I said at the beginning, it has the health outcomes that you would probably expect of a relatively deprived industrial city. It's often said of Southampton it's a northern city in the south, and it looks exactly like that when I look at the demography and the figures. The biggest cause behind those inequitable outcomes are lifestyle factors that we can change. Again, I come back to smoking, physical inactivity. Shortly behind that, we'd look at alcohol, probably a way behind that, other substance use. We look at alcohol and we think about people who have destroyed their own health and who have managed to destroy their liver or another vital organ through drinking. What we don't always see is the picture around what that's done to their family and their society, and just how much drinking problems can break up a family, impacting on people's ability to hold down a job, impacting on the relationship that people have with their partner and their children. And I think as a society we've given alcohol so much freedom and leeway that we wouldn't have given any other substance that does the same amount of harm. I can show you in North America that the rate of alcohol-related harms is directly proportional to the number of alcohol outlets. I can't show you that same statistic for the UK. And
or Southampton.
Or for Southampton, or for anywhere in England. And the reason I believe I can't show you that in this country is because we're so super saturated with alcohol outlets. We've got 10 times more, or I can't give you an exact statistic now, but I need to go back and look at that. We have alcohol available. We know that I think the research that was done up in Sheffield showed, I can't remember if it was within 1 kilometre or 1 mile, you had on average in any UK postcode 40 different alcohol outlets available to you within a mile. And that's an incredible number when you think about it. We get actively involved in the licensing committee in both cities. We object to things where they are likely to have an impact. We're hampered slightly by the fact that in England, health problems are not a primary concern of licensing. So licensing committees have to think about a number of problems when they're deciding whether or not to give a license. Crime and antisocial behaviour, the safety of children, those are primary considerations, but health isn't. That can be changed with a stroke of the pen in Westminster. All we have to do is follow what the Scottish have done, and I would strongly advocate that. I think health should be a primary consideration in any licensing decision. We know that deprivation is not just a consequence but a cause of those health problems, and we can draw you very strong links between deprivation and high rates of smoking, deprivation and higher rates of harm from alcohol, physical inactivity, etc. So the question for us is how, as a country and a city, can we start to address deprivation more completely? We've got the benefit of a growing economy in Southampton. We're going forward here. The question is what are we growing? Are we creating jobs that people would want and that people need, that give them a stable level of income? By not having adequate public transport, we restrict people's access to employment and to a range of other things that will be very good for their health. And so actually, again, public transport is very much a public health issue. I haven't started talking to the companies yet. I have had a range of discussions with transport planners in both cities, Southampton and Portsmouth, and I'm sort of working up to that. We're very blessed here as a city. We've got some really useful bits of infrastructure, if you like, on that front. The Common is incredible, and it's this beautiful space that links quite a lot of the city. We've got lovely green spaces and parks in the city centre that again could be offering that. And my plea when I meet with the transport planners these days is don't think about roads, think about parks, think about the green spaces, because what we really want is a network of green spaces that are joined up that people can get through, so that we know people are much more likely to walk if their walk is going to be pleasant. If I was to tell you that I was going to choose two things that were going to have the biggest impact on both making us live longer and reducing those health inequalities, I would start with smoking, which is still the number one reason that we die young, and still the number one reason why we've got a gap between richer and poorer communities. And next I would look at physical inactivity, which is close behind smoking in its problems, causes of health-related problems. And by physical inactivity, I mean people who are almost not entirely dependent on their couch, but who find it difficult to get any physical activity in their day, and that's very bad for you. And we've tended to focus on obesity, we've tended to focus on diets and other areas there. Increasingly, as the evidence is coming in, we're starting to realise that actually it's not getting out and moving that does you the harm. For me, it's around how do we change the physical environment that we're living in. So, what is it that we can do that would make healthy choices easy ones? And that's, for me, around how do we make active transport the first option rather than the last option. So how do we move people out of cars and get them walking, get them cycling, get them travelling around the city in a more sustainable way? When I took this appointment, one of the things I said was as much as that budget is obviously important and a useful tool, that's all it is. When you look at the £18 million of the Public Health grant, which sounds like a phenomenal sum, compare that to what we spend on health care and in treating disease, and it's dwarfed by comparison. As a city, we'll probably be spending somewhere between £500 million and £1 billion a year on healthcare. So the amount that we're putting into prevention is relatively minuscule by comparison. That said, we'll be spending across the public sector organisations in the city probably at least £1 billion a year if you added together the universities and the hospitals and the council spend and other bits and pieces. And all of that money could potentially be buying us more health if we spent it more wisely sometimes. But in that respect, how would you shift money into prevention would, to my mind, be making sure that we invest more sensibly in primary care. We've for years probably prioritised investment into hospitals for the best part of 15-20 years. So I guess for me the aim is to try and influence that bigger spend and how we do that rather than to focus purely on the public health budget, because the public health grant will probably soon be a thing of the past. I think some of the organisations down here are working really well, and I'm really grateful that those are there. We've previously discussed the clinical commissioning group here. I think that's an incredibly efficient and well-run organisation doing a great job. The local authority here is really starting to get a good feel around it as well, I think, and it's interesting coming in. It's obvious that there's been a lot of changes here, and the question is now, okay, with half as much money as we used to have, what is it that we can still do? What is it that we're going to prioritise, and how are we going to achieve that? It's probably been something we haven't done that well in public health terms, is managed to help develop the understanding of councillors of what it is that we're trying to achieve in public health, what it is that they can do that will promote health. If you go to Holland, and particularly if you go to the Scandinavian countries, you'll find local democracy is much stronger. And I think we as a nation seem to think that all the council does is empty our bins and fix the potholes and refuse us planning permission when we feel we should have it. Those are really where people see their interactions with local authorities. They don't recognise all the other roles that local authorities can and do have in promoting health and doing other good work. And as a result, we tend to disengage with local democracy. It always worries me in the UK that people will come out and vote for a general election, but they won't come out and vote for a local election.